Welcome. In this lecture, we'll be discussing subarachnoid hemorrhage. Let's first talk about the pathology of subarachnoid hemorrhage. The pathology is exactly what it sounds like. It's bleeding into something known as the subarachnoid space. If you remember, there are three different layers of the meninges. The outermost layer, right beneath the skull, is known as the dura mater. The area right above the brain tissue, or the brain, is known as the pia mater. And the area between these two is known as the arachnoid mater. Even more specifically, between the arachnoid mater and the pia mater exists this space right here, which is known as the subarachnoid space. This is important because this is an area that houses all of the CSF. It should also be known that all of the arteries of the circle of Willis and other arteries throughout the brain are located in this subarachnoid space. Thus, rupture of a blood vessel will cause leakage of blood into the CSF, and thus into the space. It should be known that arterial pressure is higher than venous pressure throughout the body, including within the brain. When there is rupture of an aneurysm or a blood vessel, this leads to rapid accumulation of blood into this confined space, or the subarachnoid space. This gives the body no time to adapt, and this leads to a multitude of symptoms and complications typically caused by an increase in intracranial pressure. Now, there are a multitude of risk factors associated with subarachnoid hemorrhage, but by far and away the most common is something known as a saccular, or aka a berry aneurysm. It should be known that berry aneurysms are typically taught to be related to autosomal dominant polycystic kidney disease. But not all berry aneurysms are caused due to ADPKD. Now, what exactly is a berry aneurysm? Well, here on the left is a demonstration of what a berry aneurysm is. Typically, you have some sort of weakness in the arterial wall. This leads to an increase in pressure, causes ballooning out of the vessel. This looks like some sort of berry, hence how has its name. This saccular aneurysm or berry aneurysm can rupture, which will lead to bleeding in something known as the subarachnoid space. Remember, this high pressure gradient causes rapid blood accumulation, increased intracranial pressure, which leads to all the symptoms that we'll talk about in the upcoming slide. Now, there are other causes of subarachnoid hemorrhage, such as hypertension, cigarette smoking, and even sometimes some medications or illicit drugs can cause it. But by far and away, the number one risk factor is going to be berry or saccular aneurysms. Now, let's talk about the symptoms that we see with subarachnoid hemorrhage. Typically, what you'll see in presentation is a sudden onset of a severe headache, typically described as the worst headache of my life. Now, it should be known that sometimes people can present with 10 out of 10 headache pain, but have an underlying or history of headache, such as migraine or cluster. Subarachnoid hemorrhage will present differently than previous headache presentations. It should be known that words such as thunderclap headache, or even terms such as worst headache of my life, typically is not talked about or presented on test day. But what you should be looking for is some sudden onset of a 10 out of 10 really bad headache. You'll also see other suggestive findings, such as nausea and vomiting, which is typically due to that increased intracranial pressure that we talked about in the last slide. You also typically see some sort of focal neurologic deficit. Now, the symptom presentation, it typically depends on where the hemorrhage is occurring and what blood vessels are taking place and where the blood is accumulating. The focal neurologic deficit will typically be unilateral muscle weakness, upper or lower extremities, maybe sometimes dysphagia or aphasia, trouble speaking. Can also be blurred vision or abnormal extraocular eye movements. These are all suggestion of a new onset for neurologic deficit. And then another high-yield topic, or high-yield presentation sound, is going to be something known as meningismus. Meningismus is not the same thing as meningitis. Meningitis is an inflammation of the entire meninges. Meningismus is due to irritation to a specific section of the meninges. What happens here is that blood is accumulating into the subarachnoid space. This blood does not belong there. Thus, an inflammatory cascade is activated. This release of cytokine causes irritation to the meninges via the inflammatory response. This irritation can cause such symptoms as neck stiffness, which is commonly seen in meningitis. You can also get headache, of course. Photophobia can also be associated with it. Thus, it should be known that subarachnoid hemorrhage is typically compared to meningitis because of this neck stiffness or meningismus that can occur. But these individuals will not have systemic symptoms, such as chills, fever, muscle pains, arthralgias, etc. The big takeaway from this slide is to look for a sudden onset severe 10 out of 10 headache with neck stiffness and a new onset focal neurologic deficit. That is highly suggestive of subarachnoid hemorrhage. We'll now talk about the diagnosis or the workup of subarachnoid hemorrhage. We'll first go over two high-yield exams or two high-yield tests that we do, and then I'll break it down to an algorithm. The first test, which is typically a rule of thumb for most neurologic cases, is always going to be started with a CT head without contrast. This is extremely beneficial and helpful for looking for blood loss or bleeding. Note that CTs have greater than 90% sensitivity, some sources even say 95% sensitivity, for bleeding if done within the first 6 hours of symptom onset or symptom presentation. Sensitivity drastically drops after 6 hours of presentation due to the blood in the subarachnoid space being broken down and redistributed throughout the CSF, which we'll talk about in the next diagnostic test. That breaking down of the blood makes it harder to detect imaging. So what do we typically see on CT head without contrast for subarachnoid hemorrhage? Well, the test will demonstrate something known as a star-shaped pattern. This star-shaped pattern typically is due to blood layering in the basal cisterns. Here's a great picture of a star-shaped pattern. If you can see, we have this darker cerebral tissue on the outskirts, and in the middle here, we kind of have this lighter area. If you were to draw a line in these light areas, it'll look very similar to this, which looks like a star. Hence how it's got its name, star-shaped pattern. This is a classic image shown with subarachnoid hemorrhage and something I would definitely be on the lookout for on test day. Now, what happens if the CT head is negative? Well, we can do something known as a lumbar puncture or examine the CSF. This is typically done, as I've mentioned, if the above is negative. Now, the highest sensitivity for this is going to be between 6 to 12 hours after onset. Remember, the blood that is accumulating at the bleeding site is going to be broken down and redistributed throughout the CSF. This causes it to spread, and we can now examine this via lumbar puncture. What you see is something known as xanthochromia. What exactly is xanthochromia? Well, here's an imaging comparing the two. On your right here, we have a normal CSF. Notice how it's clear. On the left, we have something known as xanthochromia, or this yellow-like distribution. Well, why exactly is it yellow? Well, that blood that breaks down consists of heme. That heme is broken down into a multitude of different things. One of those things is bilirubin. Bilirubin is typically what gives the CSF in subarachnoid hemorrhage its yellow-like color. So these are definitely the two big tests that I would be on the lookout for. They will either provide it to you and expect you to know what the next step is, or that it is subarachnoid hemorrhage, or they'll ask you which of the following is the next best step. So how exactly do I determine which one do I do? Well, let's go through the algorithm. The first thing we're always starting with is a CT without contrast. This is a general rule of thumb for most neurologic cases. If this comes back positive, aka if you can see the blood on that star-shaped pattern, then we have to look for the source of bleed. Thus, how do we do this? We typically get something known as a CT angiography. CT angiographies are very good for looking at the vessels or the vasculature of the brain. Obviously, you can do angiography in multiple different places throughout the body, but in this case, we're talking about it of the brain. This will help show us where exactly is the leak coming from? Where exactly is the bleed coming from? To help depict, is there something that we can do about this? Thus, once CTA is done and we find the source of the bleed, the next step is always going to be to contact neurosurgery, as these people might need or might require aneurysm repair, which we'll talk about in the upcoming slide. If, on the other hand, that CT head that we start out with is negative, but we still have a high suspicion for subarachnoid hemorrhage, then we can get our lumbar puncture. Remember, our lumbar puncture will be looking for xanthrochromia, or that yellow-like distribution. If this comes back positive and demonstrates xanthrochromia, then we would follow the exact same steps and get a CT angiography to look for the source of the bleed. If even the lumbar puncture is negative, then it might be something else, which we'll talk about in our last slide. Now we'll briefly discuss the treatment of subarachnoid hemorrhage. Now we always start with ABCs, airway, breathing, and circulation. It is important for BP management in individuals with subarachnoid hemorrhage. Typically, the goal is somewhere between less than 140 to less than 160. This depends on presentation, symptoms, risk factors, as well as what study you're using to help guide you in decision making. Thus, you should not have to choose between either or for test day. Just know that subarachnoid hemorrhage is typically a bleed in the brain, and the SBP goal, or the blood pressure goal, is going to be lower than an ischemic stroke, which we'll talk about in upcoming videos. The gold standard of treatment is typically aneurysm repair. This can either be done via clipping or coiling, which we'll talk about in the next slide. Now, treatment is going to usually be done based off what complications individuals are presenting with. It is typically done to prevent complications. Now, what complications exactly are we talking about? Well, there's three big ones. Let's first talk about the first one, which is rebleeding. This weakened arterial vasculature, which has already been bleeding, is weak. Thus, it is prone to rebleeding. Rebleeding for subarachnoid hemorrhage typically occurs between 1 to 3 days or 24 to 72 hours after the initial bleed. How this will typically present on exam day is you'll have someone who comes in with a subarachnoid hemorrhage, and all of a sudden they'll have worse neurologic exam, new focal neurologic deficits, nausea, vomiting, seizures, stuff along those lines, after improvement of stabilization. Note how I'm emphasizing 1 to 3 days. You'll see that the next complication presents very similarly to this. The big difference between the two of these are going to be time frame. The treatment of rebleeding is typically going to be aneurysm repair. You can do this either with coiling or clipping. Typically coiling is less invasive and clipping is dependent on what vasculature is involved. You'll generally never have to be compared or choose between these two. The big takeaway for rebleeding complication is that it typically occurs between 1 to 3 days, and you'll have worsening neurologic presentation. The treatment is going to be aneurysmal repair. Now, the next complication is going to be compared to this, something known as vasospasm. So vasospasm is going to be more common between 3 to 14 days. But please note that typically, or the studies suggest that vasospasm can occur as long up to 21 days. Thus, we typically treat people with vasospasm for 21 days. This most commonly occurs between 5 to 7 days. What happens here is that we have delayed cerebral ischemia, or vasospasm, which narrows cerebral arteries. This basically leads to ischemia, aka a mini stroke. These individuals will also present with a sudden neurologic deficit. Whatever it may be depends on what vessels are undergoing vasospasm. The big difference between rebleeding, up here, and vasospasm is going to be time. If someone gets worse on day 5 versus if someone gets worse on day 1 after they present. That is how we depict what's going on. Obviously, in real clinical practice, and maybe even on test day, for both of these individuals with worsening neurologic exam will still get re-imaging. For rebleeding, that re-imaging will typically show a bleed. For vasospasm, you can actually see vasospasm occur on imaging. Most of the time, that will not be given to you on exam day because that gives away the answer. Thus, you need to imply what's going on based off of the time frame. Treatment for vasospasm is typically going to be with some medication or a calcium channel blocker known as nimodipine. Sometimes we'll also give IV fluids to either prevent or treat vasospasm. Now, there is some discrepancies upcoming in literature that suggest now that nimodipine may not be as beneficial as we once thought. This is conjecture, and this is not important for exam purposes. This is a debate upon neurologists and neurosurgeons currently throughout the literature. Please note for exam day, your gold standard treatment is always going to be nimodipine for treatment and prevention of vasospasm. So typically rebleeding and vasospasm are compared to one another. One that kind of sits alone as a complication is something known as hydrocephalus. Hydrocephalus occurs because the blood blocks CSF flow. This leads to acute obstructive hydrocephalus, or swelling of the brain due to CSF accumulation. What happens here is that heme that's being broken down in the CSF accumulates and forms big globs. If you remember, you have something known as arachnoid granulations or arachnoid villi, which are the primary structures that drain CSF. The choroid plexus, on the other hand, has no issue with producing CSF. Thus, we are unable to drain when these are blocked, and we are still producing CSF, which leads to hydrocephalus. Typically, this symptom is going to be ICP related, increased ICP, which will typically be demonstrated as Cushing's triad, which is three things: hypertension, bradycardia, and decreased respirations or irregular respirations. You can see either or, and other signs such as papilledema, altered mental status. Typically, imaging is actually helpful here and sometimes given to you on exam day. What you'll see is these large ventricles here, which is all due to this inability to drain the CSF. That is your hydrocephalus. Now, it's a common rule of thumb that when you have fluid overload in the brain, we typically treat this by draining. This can either be done by an EVD or an external ventricular drain, or even sometimes a VP shunt. Hydrocephalus is due to, the pathology is due to blocking those granulations, the inability to drain CSF. These are far and away the three most commonly tested complications, and is typically how you are treated on the treatment, you're tested on the treatment of subarachnoid hemorrhage. Now we'll quickly talk about another disease that subarachnoid is compared to. SAH is compared to two diseases: meningitis, as we briefly talked about and will be covered in another lecture, and something known as reversible cerebral vasoconstriction syndrome, or RCVS. Now, the pathology here is that we have this transient coming and going narrowing of cerebral arteries, typically due to some dysregulation of vascular tone. This leads to no inflammation and no permanent vessel damage. It typically involves some sort of functional vasoconstriction triggered by something. That something can be caffeine, medications, some different type of stimuli. And it is typically self-resolving, only lasting between 1 to 3 months. The symptoms, as you could guess, are very similar to subarachnoid hemorrhage. The most common one being is recurrent thunderclap or worse headache of my life. Look for someone who is having recurrent, close to one another, headaches, typically presenting to the hospital for the worst headache of their life multiple times within the past week or maybe sometimes a month. You also have other symptoms, such as nausea, vomiting, photophobia, focal neurologic deficit, altered mental status, all suggesting or all similar to subarachnoid hemorrhage. So how do we typically compare these two? Obviously, recurrent thunderclap headaches is very, very helpful, but maybe sometimes they won't give that to you on test day, and they'll make the question a little bit harder. Well, we'll still follow the same exact scheme, but in this case, our first test, or our CT head, is going to be negative, even within the first 6 hours, because there's no bleeding that's taken on here. It's just going to be vasospasm or vasoconstriction. We'll then follow the same algorithm and we'll do the lumbar puncture. The lumbar puncture will also be unremarkable. The CSF will not have xanthochromia because there's no blood to be broken down because there's no bleed occurring. The gold standard here is going to actually be a CTA or an MRI. Either or works. This will show something known as string of beads appearance. Please note on test day, they will not say string of beads is seen on CT imaging. Instead, what they'll do is they'll describe it. Maybe something along the lines of multifocal segmental narrowing and dilatation of cerebral arteries. If we have narrowing and dilatation, and then narrow, right, and then narrow, and then dilatation, and then narrow, and then dilatation, this looks very string of beads-like. Thus, what they are typically asking, or going to ask for this disease, is either how do you diagnose it, and it's going to be CTA/MRI, or what is the disease compared to subarachnoid hemorrhage. They typically do not test treatment, but just for completeness sake, I will say that RCVS is treated by removing triggers, managing headaches and blood pressure, and using calcium channel blockers like nimodipine for symptom relief. The condition is self-limiting and typically requires close monitoring for complications. Overall, the treatment is typically supportive, more so than not. And that concludes this lecture on subarachnoid hemorrhage.